My name is April Megginson. I am the Associate Board Chair of MASCA, which is the Massachusetts School Counselors Association. And Associate Board Chair is like a fancy way of saying President-elect. I started off in education as a first grade teacher, and then I became a school counselor. I worked at school counseling for 9 years, 7 years at the high school level, 2 years at the middle school level. So I've pretty much been in, and now I teach at the college level. So I've pretty much covered all realms. And John and I are really excited to talk to you today. So I'll let John introduce himself.
Yeah, thank you, April. John Crocker, I'm the Director of School Mental Health and Behavioral Services for Methuen Public Schools. I'm also the founder and director of the Massachusetts School Mental Health Consortium, which is a group of districts across the state that are committed to advancing school mental health, resource sharing, collaboration, and a lot of implementation. We have about 130, 140 districts that are part of that organization right now, and really it's an opportunity to work in a supported fashion to get school mental health off the ground. So thrilled to talk to you all today, and think we want to know who you are. So we are going to use the chat a ton. If you could open up the chat, and I guess I would love to hear from you in the chat. Who are you? What's your role? Where are you from? What district are you representing? I know a bunch of you got in there and did that already. So for those of you who have just joined us, we'd love to be able to tailor this discussion to who you are. So in the chat, what do we got? Haverhill, Springfield, we got grade 5 math, we got first grade teacher in Springfield, that's awesome, thank you. Awesome, Leominster math teacher. Bridgewater, Raynham, school adjustment, cool. Middle school Spanish teacher in Norwood, high school English teacher. All right, so we got people all over the state, all kinds of different roles, which will make for a very interesting conversation today. Because I think that I love that we framed this as for all students, right? And the bottom line is that there is no, we don't have the luxury of saying that mental health is something that a couple people in an office are going to take care of for a school. It's everyone pulling in the same direction. Everyone contributes to the mental well-being of students. So I'm hoping that we can all learn something, all gain something from this discussion. There's going to be some technical, clinical discussion at times. We'll try and balance that with a lot of tier one, a lot of something for everyone. So thank you for dropping that info into the chat. April and I are just going to kind of bounce back and forth between each other. I feel like it's just going to be awesome. So here we go. April, you want to take it away?
Sure. So some of the learning, oh my gosh, it's summer. Okay. Learning objectives for today are just kind of understanding the history and unique role of the school counselor, the SAC, the school adjustment counselor, and the school social worker. We're going to talk about how mental health problems can impact kids in schools and how student support personnel can address it. And we're also going to learn about the comprehensive school mental health system and how they can impact schools and students. So let's go into this history and unique roles of school counselors. So the history of guidance counselor. So guidance counselor, for a lot of people, is kind of, it's a bad word. It's a word I don't really particularly love. In the beginning, in 1908, we had a Bureau of Vocational Guidance, but really guidance counselors came to the forefront during the space race. So the Department of Defense was looking for people to become more interested in math and science and pursue those degrees so that they could then help us win the space race. So that's kind of, the Department of Defense provided a lot of money for school or guidance counselors to help guide kids into math and science courses, as well as math and science majors. So it was really like this huge push to push people into the math and science arena. after that, and a lot of times there was no standardization, there was no like license, you just became a guidance counselor. You might have taken a class or two or had some professional development. In the 70s and 80s, that's when standardization really occurred about what are we looking for within licensure. The 80s to 90s led to more of a comprehensive program. In the 90s, ASCA, the American School Counselors Association, released a national model, and that's when nationally we changed to school counselor, because school counselor was more it aligned better with the actual work that we were doing on a day-to-day basis. We were no longer the guidance counselors who help guide kids into different careers. That was one part of our work, but it wasn't everything that we did. And then the 2000s to present is a really big push on evidence-based instruction and data-driven practices. As a state of Massachusetts, we just recently, like within the last 2 or 3 years, changed from guidance counselor to school counselor. A lot of schools still use that guidance counselor terminology. I would suggest that they not. There's a lot of research that says that the perception of what a guidance counselor is lower than, like, people think that you have less education, that you're able to provide less services for students than what a school counselor is, and that's really how people are being trained. So the history of the school adjustment counselors, so this was really hard for me to find because school adjustment counselors only exist in Massachusetts. So this is a very unique niche. And so it is basically a licensed mental health counselors who work in the school. Again, specific to Massachusetts. So this is what I did find. So originally DCF had, like, I don't know, they got some kind of grant, they had a whole bunch of money, and what they did was they put a whole bunch of SACs and school social workers into schools to help, like as a preventive measure, to help prevent kids from going into foster homes, help families better deal with the kids, to help kind of negate the school to jail, school to prison pipeline. So there was a lot of great reasons why SACs and social workers were brought into Massachusetts schools. Of course, at some point that money dried up, and then they were no longer able to financially support these positions. And what ended up happening is DESE took over the licensing for those positions. And the one thing that kind of school adjustment counselors continue to have maybe problems with is that there's no specific national organization of school adjustment counselors, and there can be a lot of ambiguity in the role. So I've seen people as school adjustment counselors doing a lot of what I think a school counselor should be doing. I see them doing a lot of special ed work. Sometimes that all depends on how they're financed. So sometimes the money is very, whatever the budget line is, then they only work with special ed students versus working with the general population. So they're kind of just all over there, all out there doing all different kinds of things, just helping students be as successful as they possibly can. So education of a social worker is just a little bit different than the education of a school counselor or a licensed mental health counselor. And school social workers really come from a environmental or a systems approach. And so this is just kind of a little blurb from the National Association of Social Workers. For over 100 years, school social workers have been providing a critical link between school, home, and community. The school social work profession has consistently focused on coordinating the efforts of schools, families, and communities towards helping students improve their academic achievement and social, emotional, and behavioral competence by using its unique perspective of viewing the person in his or her environment. So there's really a lot of like community engagement, understanding the services that are in the community, helping families tap into those resources. And that's the kind of training that a social worker brings to the schools. So what's the difference between these roles? We hear social worker, we hear school counselor, we hear SAC. what's really going on. So I kind of wanted to I thought this was kind of, hopefully this will help you understand. But as school counselors, we're working on academic concerns, college and career readiness, and we're trained to work with youth. That's school counselors. As social workers, they're engaged in a systems approach, and they're heavily involved with working with families and the community. A school adjustment counselor is highly trained in individual mental health counseling. Social workers and school adjustment counselors tend to have more of that mental health clinical experience, but you never know if that's just kind of where we see them. School counselors and school adjustment counselors, usually those programs are almost exactly the same, except for like a 1 or 2 classes different. So really, a school counselor is getting a lot of those same courses, like diagnosis, like treatment, like all those things. They're just not having an internship in a clinical setting.
Yeah, and April, I know we've chatted a few times about the blurring of the lines between especially the school counselor and the adjustment counselor role now. And to your point, there are some programs that, training programs that really don't differentiate at all anymore. And it really is more a function about where people land and the culture within the building, how people have typically been allocated in terms of providing services, and much less about the readiness to provide those services, which is just a unique situation that I think is starting to unfold more and more.
So one of the things that's really important that all 3 people are working on is the social and emotional health of our kiddos. I see that somebody asked me about what do I consider school psychologists. Typically, school psychologists would also possibly work on social emotional, but almost all my experience has been school psychologists are really trained in the testing and providing interventions and accommodations and modifications for special education students. And that tends to be what I've seen in the school setting. Again, each school is so different. Each district is so different. They really just rely on what they know or what they've had before to do that kind of work.
Yeah. One of the things that we're going to go over pretty heavily is a comprehensive staffing model, which would try to leverage these roles toward a common end where we're not parsing out domains of need, where we're not saying, hey, school counselor over here, take care of these academic concerns, and then we'll have the school adjustment counselor do the mental health thing for 2,000 kids in a building. Oh, and by the way, we need a school psychologist to do some testing. We're trying to it's an offer of a staffing model that would really try to leverage all of the experience and all of the training that a staff member brings to the table, instead of kind of parsing out those different domains of need.
I think you said that perfectly, yeah.
Cool.
And just because I think people think there's so many differences between these roles, I think they're all very similar. I want to look at our DESE SMK, so our subject matter knowledge. What is the education, what's the training, what kind of subject matter knowledge do people have to have in order to have one of these degrees? So it's one license is for school counselor, the other license is school adjustment counselor / school social worker. So they have 3 shared SMKs, which are like verbatim, word for word, federal and state, municipal and school laws and regulations, knowledge of strategies used for prevention and treatment of substance abuse, physical and sexual abuse, the spectrum of mental illness and violence in pre-K through 12 students, and the theories of normal and abnormal intellectual, social, and emotional development. If we were to look at these separated, the ones that are kind of different colors, so the purple ones are very similar, the red ones are similar, basically working with families and communities. Understanding learning disorders is in the green. The purple one is understanding diagnostic instruments. So speaking from the college level, we don't have different classes for all this stuff. It's the same class, right? So people are taking the same class. But if you noticed, kind of the big or the two main differences is that school counselors have a lot more of that career counseling or college counseling. They also are required to have group counseling, knowledge of statistics, psychology of learning, and the philosophy, principles, and practices in school guidance counseling. So if we look at a tiered approach, and we're going to get into this a lot later, but I just wanted you guys to be thinking about how they're trained, how people are trained. And so school counselors are trained to provide preventive curriculum, tier 1, group counseling, tier 2, individual counseling, tier 3. School adjustment counselors and school social workers are typically trained to provide group counseling and individual counseling. It's not to say that they're not taught preventive curriculum, but like we actually, at least my school, my students are like required to teach. We talk about classroom management styles because being in the school is a different, is totally different than being at the clinical setting. So you have to be prepared for a lot of different environments. And so the school counselors have that kind of training, whereas our school adjustment counselors do not.
Okay.
I think somebody else asked about a copy of all these slides, and yeah, we can give a link out to that, don't you think?
Yeah, of course. Yeah.
Okay.
So a quick activity, and we're going to use the chat for this, and we're not going to wax poetic too much about it because I think it's going to be pretty obvious. But what do you think? In the chat, how often and in what ways do problems related to mental health and trauma impact your work with students? Are we talking about like, well, this happens every like 6 weeks, I have a problem? Or is this every day, all the time, all our kids? Lots. What do we got? I will sit here in silence awkwardly if we don't get any chat. All right, much of the time, great. Top tier, daily, every day, okay? So we're seeing all the time. Okay. What have you noticed regarding the impact of mental illness and trauma on academic growth and achievement? Are these things linked? Do you see it? Is this explicitly linked in your day-to-day work with kids? Freddie says, yeah. Susan, yes. You're thinking they're linked? Okay. And here's the big question, right? How prepared are we, wholesale, all our staff, to support students who are experiencing mental illness and trauma in the classroom? Do we feel like we're super prepared? Are we, is it somewhere in between? What do we got? Few teachers understand trauma. Somewhere in between, says Amy, in between. Claudia, you're feeling prepared. I like that. Somewhat prepared. Okay. I think I'm seeing a mix, and I typically see a mix. The bottom line is that, you know, we're increasingly seeing students with mental health needs and trauma, and we need to be prepared for this because there is an academic link. So I appreciate you now you are engaged in the chat, and we can refer to this all the time. So be prepared for that. I want to talk very briefly about just the prevalence of mental illness. For those of you who don't know, this is kind of the quick introduction to how big of a problem this is, right? 20% of students will experience a mental health problem of mild impairment, about 10% severe impairment. And this quote is, I love this quote, but you know, I hate it also because it's real. But half of all lifetime cases begin by age 14. Chronic disease of the young. I think that's how we have to think of this. This is something that, unless we start to adopt a more preventative and proactive stance toward mental health, then we're going to have a problem that persists into adulthood and is never going to get better. We're never going to reduce these prevalence rates. Another quick just orientation slide, right? Depression impacting students at an increasing rate. Yet, unfortunately, about half don't receive treatment. And that's from the National Institute for Mental Health. So they know what they're talking about. When we talk about what we are ultimately going to have to pay out as a result of failing to provide mental health services, we're talking about a hit on academic performance and increased rates of crisis. Attendance rates are going to drop, lots of behavioral concerns. You know, April mentioned the school to prison pipeline. It's a real thing. It's something we have to be concerned about. Increased substance use, incarceration, healthcare costs. Bottom line is that mental health impacts all the things, right? All of the outcomes that we hold near and dear. If we don't first address mental health needs, then we don't get to improve in any of these areas, or at least we don't improve as much as we could otherwise. When we talk about the link to academic achievement, we see that when we unpack data relative to school mental health or psychosocial outcomes, using this measure, the Strengths and Difficulties questionnaire, we saw that GPA was on average 13% lower for all students, and that there was a 45% increase in absenteeism for students that scored in the high or very high range on this measure. So we're talking about numbers that are, we're not talking about a few students, right? We're not talking about a small proportion of your classroom. We're talking about 1 in 5 and a pretty significant impact on their academic outcomes as a function of not having the mental health issues addressed adequately. April, you want to weigh in on this? Anything else you would add?
No, I mean, I think you say it well. I think one of the things that I get concerned about, or one of the things that I think is rising, is this higher state of anxiety of kids. So depression almost doesn't seem as important as the anxiety, the social anxiety. Just these kids are exposed to so much information all at once, and their little bodies are not able to kind of process it, I think.
Yeah.
And it continues to be a problem. I think there's a lot of research that shows that, if we think of our Maslow's hierarchy, right? Kids need certain things before they can get to that education piece. And that's what hopefully, we need to be working on some of these things before we could get to that part.
Agreed. From the chat, what is the percentage of these being comorbidities of another underlying issue? So, I mean, we'll talk about prevalence rates relative to anxiety and depression. When we talk about comorbid anxiety and depression, that's something we're still digging into. At least from the local level, I'm sure NIMH you could dig in on that a little more, but suffice to say, anxiety and depression, the comorbidity between those two presenting issues is relatively high. Christine says, we will see more of this in the fall. Yes, we will, Christine, unfortunately. Okay, here we go. We're going to keep moving. So we touched upon this a little bit. April did a really fantastic job framing this idea of traditional views of school mental health staff, right, and guidance counselors. And I think that what I want to avoid, and what we've really tried to champion in Methuen and through MASMHC, is avoiding a refer and hope model. And what is that, right? It's filling out the paperwork saying that I sent in the referral to the community-based mental health provider, and then we wash our hands of the problem. We say we did the thing. And we know that that doesn't work, unfortunately. Community-based mental health is a wonderful part of the solution, but unfortunately, the prevalence rates that we're dealing with are tremendously high, and it's very common to see a 6 to 9 month waiting list for students to receive care in the community. So this is a problem that is absolutely resting on our shoulders as school systems. It's also the case that there's this long-standing misconception that school mental health staff are not or cannot be primary service providers, that they don't provide evidence-based services, that it's a lot of check-ins, and that's something that we want to, that we seek to change in terms of the preparation of our counselors and what we ultimately position them to do in schools. I think that's one of the key problems, is that, one of the things that we want to resolve is not the fact that, these counselors can't do, it's that we haven't positioned them to do the thing that we need them to do. And that's a function of just the culture that has persisted within schools, and that's no one's fault, right? That's us that's us continuing with a model that we think is the right thing, but ultimately our kids need something different now. All right, let's keep moving. So, we talked about this a little bit before too. This traditional role of guidance counselors that has lived on in schools and fueled a misconception of really what we can have them do. Training programs have absolutely changed. They are much more aligned with mental health with mental health services and supports as opposed to simple academic or post-secondary counseling. In fact, some schools don't differentiate at all, as we stated, between adjustment counselor and school counselor in terms of the training programs. And nationally, many school districts have really, unfortunately, maintained a traditional view of guidance counseling, but that's because we haven't done a great job, as a field, of really advancing the discussion around what these staff can do. Let's keep moving. So I want to talk about community-based mental health a little bit because they, like I said, they're a huge part of the solution, but again, they can't be the solution. And that's just because, well, for one reason, by design, our community-based mental health providers are positioned to react to the worst situations that we hand them. It's about reaction to crisis. It's about addressing the needs of students when it gets so bad that we are forced to contend with the problem. And that's not a great health model, right? That doesn't leave a lot of room for prevention, proactive service delivery, and reducing those prevalence rates. But the reality right now is that, we want to have our cake and eat it too. I would like to be able to overcome these barriers to community-based mental health, but also become a part of the solution in schools where we have direct contact with these students and we can engage in the prevention and proactive service delivery work that is so necessary. So things like transportation, right? Things like childcare, or navigating insurance, those can be, that can be the end game to access community-based mental health. And that's really unfortunate. It's also the case that if we actually position a student to get community-based mental health care, we have to also contend with this very depressing graph. So the reality is that about 28% of students don't make it to their first appointment in a community-based mental health setting. And then after about 3 months, we're looking at 91% of students having dropped out of services. And that is 3 months is typically what we see from the literature as being the bare minimum amount of treatment necessary to produce change within, or to start to see some positive outcomes. So if we put all these depressing statistics together, we see that, let's imagine 100 students, right? We know from research that about 50% will never be identified that need services. So we're down to 50 kids who are going to get services and 50 who won't. We also know that about 75% of students who do receive mental health services across the country get those services in schools. Okay, so that leaves about 25% of our original 50 kids who are getting services in the community. They've broken through all of those barriers to get services. So we're looking at like 12, 13 kids who are getting services in the community. Well, 4% will receive 6 or more sessions in an outpatient setting. So we're talking about 4 kids out of the original 100 that will actually receive an appropriate amount of care within a community-based mental health setting. And that to me is a very sad reality. I think that, it makes me think we are the primary source of mental health services for students, and we can provide prevention-based services. This is not to knock community-based mental health. I think they're doing everything they can, but I think that it's just an unfortunate reality. And by design, that prevention is not part of the agenda for community-based mental health agencies. Anything else you would say to that, April?
No, I just, kind of going off some of the stuff that's going on in the chat about, cultural perceptions, negative cultural perceptions about mental health. And I said that kind of our argument is if this is offered in the school, it could really decrease those negative ideas or negative perceptions about what mental health counseling is, how we can help service those kids. If it's part of like an all-inclusive school setting, then that I think that's kind of our argument. That's part of our argument as well.
Agreed. You know, when everyone receives mental health literacy curriculum, then the stigma associated with talking about mental health no longer exists, or it exists less. And I think that that's something that I would certainly advocate for at Tier 1. We're going to keep moving because I want to make sure that we get through all of this stuff. I do think that we are ultimately uniquely positioned to provide services and supports to students in schools. We've seen through a discussion about the services and supports and the training that school counselors and school social workers and school adjustment counselors are, what they are trained to do is evidence-based work. It's not the case that we are relying on a traditional guidance counselor role to meet the needs of these students. I can say personally, my training was entirely based in evidence-based therapeutic care. And entering into a school, it was strange to see that a comprehensive model where I would start to provide therapeutic care to students immediately wasn't necessarily just part of the culture of the schools that I was working with and the schools that were around me in other districts. So I think that we need to reflect on the fact that mental health problems are pervasive. This is not a couple kids in a couple classes in your school. We're talking about 20% on average, in that we can and should rely on community-based mental health agencies as part of the solution, but relying on them solely is going to result in no change in terms of the prevalence rates, because they're not going to be positioned to provide prevention or to provide proactive service delivery, and that we know that there are a lot of barriers to accessing community-based mental health that we need to work through. We also know that the outcomes associated with mental health improve outcomes that we hold near and dear in education. So when we do right by the mental health of our students, we see gains academically, from an attendance standpoint, behaviorally, post-secondary, matriculation. So there's our argument. We are going to run through one of the, I guess I want to offer the perspective of what Methuen Public Schools has gone through in terms of our story and how we established a comprehensive school mental health system. So there will be some discussion about kind of the lead up to that, because I think it's important to understand what resources are out there to support this. We started on some work with the National Center for School Mental Health about 5-6 years ago. They're an incredible group, lots of resources. I would strongly recommend checking out their website. But bottom line is, we entered into a relationship with them to be able to establish a comprehensive school mental health system. So what is that, right? This is the definition, but bottom line is it is another tiered system of support that works well with other tiered systems of support. We'll talk about what that is if you're unfamiliar, but ultimately we want to provide preventative care. We want to provide universal supports for everyone. It does have a sensitivity to collaborative partnerships with community-based mental health agencies, and it's very much sensitive to the use of evidence-based services and supports. We want to use strategies and supports and systems that have been proven through research to have an impact on outcomes. So here's your fun triangle that you would be very sad if you didn't have a triangle within the presentation. April already offered one, so this is your second, and you'll get a third later on. But the reality here is this is how we organize the supports within the social, emotional, mental health tiered system of supports that is a comprehensive school mental health system. So we're talking about things like mental health literacy at Tier 1. We're talking about social emotional learning curriculum like Second Step. I see some people in the chat talking about Second Step. Awesome. We're also talking about embedding social emotional learning instructional practices in all content areas. And that's less about the curriculum, and it's more about how you deliver your content such that you are fostering social emotional competence. We also want to talk about Tier 2, right? The forgotten tier, targeted selected group-based supports, timed tracked interventions, think group therapy, and then Tier 2, so individual intensive intervention, think individual therapy, and wraparound services. We went through a process with the National Center for School Mental Health. It was called a COIN. A COIN is basically a learning collaborative where we were able to work with about a total of 12 districts across the country over the period of about 16 months to be able to resource share and collaborate and receive some targeted assistance to be able to implement a comprehensive school mental health system. We went through a number of trainings to be able to gain some competence relative to continuous quality improvement practices. So use of PDSA cycles, which we'll talk about in a minute, but basically using this learning collaborative to adopt the national performance measures that have been drafted by the National Center for School Mental Health and to implement a comprehensive school mental health system the best we could. We're going to gloss over this, just a fun map. We used the SHAPE system to be able to measure our progress. This was really, this is a fantastic tool to be able to gauge the degree to which your district is adopting the national performance measures for school mental health. And those measures are included here. There are a lot of hot links in this presentation that you'll ultimately be able to click on later. But things like teaming, do you have a school mental health team? Have you conducted a needs assessment or resource mapping? Are you engaging in universal mental health screening? Do you implement universal supports for students at Tier 1? And do you have early intervention and indicated treatment services and supports at Tiers 2 and 3? So what I really appreciate about our experience with the COIN is that there was a sensitivity to quality, right? Do we have evidence-based programming? Are we screening? Do we have teaming? But also sustainability. And I don't think anyone gets into the field of mental health to market and promote the impact of their system. But the reality is that we are oftentimes number one on the chopping block when it comes to budget season. We need to be ready with data to be able to say, this is our impact on the student population. This is what we bring to the table. Here's what we offer. Give us more. I talked about PDSA cycles. This is just a way to frame the work that we do. We start, and I think a good example of this is universal mental health screening, right? When we talk about screening, we're talking about using a tool to identify a student relative to a specific presenting issue. So if I was going to implement a PDSA cycle for screening, I might say, we're going to screen one student using one tool, and we're going to look at the data. We're going to carry out that plan. We're going to analyze that data. We're going to study that data. What did we learn from it? How can we use it? How can this change my practice? And then ultimately, we're going to say, should we do this more? Should we scale this practice up? And what that leads to is iterative PDSA cycles that lead to large-scale implementation over time, but we're checking that implementation to make sure it works. We're looking for barriers early on. We're looking for problems early on that we might not have accounted for if we said, you know what, tomorrow we're going to screen everyone for suicide at the high school level. We're just going to see how it goes. That could lead to incredibly damaging results and a failure to respond to students' needs. But if you get to that over time and go from 1 student to 10 students to a class, to a grade, to a school, to a district, then you're able to adjust your practice over time so that you're not falling on your face when you decide to screen for the first time. Does that make sense to people? I want to pause and see where we're at. Are you all asleep yet? No, I got one person. All right, that's good. Moving on. All good, says Chris. Well, thank you, Chris. We're going to skip this. We don't need that. We don't need that. All right, mental health initiative in Methuen. Let's talk about what that looked like. Where did we begin? What were the most important aspects? Here's a quick overview of kind of what we did, implementation highlights. So, I mentioned district and building-based school mental health teaming. We have that. We conducted resource mapping and needs assessment. So basically, like, what do we have and what do we need, and where do we need to go with this? Universal mental health screening. We've advanced that practice to grades 3 through 12 using a multitude of different screening tools. Joanne's wide awake, thank God. Group therapy program in all schools, mental health parent and student advisory council. We have wonderful partnerships with some local community-based health providers. We established the Massachusetts School Mental Health Consortium. I mentioned that. Bridge program. Those of you who here is familiar with the Brookline Center, the BRIGHT model? Anyone? Excellent. Excellent. We got a couple people. Bottom line is bridge programs are designed to support students returning from long-term absence and typically psychiatric hospitalization. You know, old model, student returns to school after a long-term absence and we say, have at it, enjoy math. And there's an attempt maybe at trying to support that student in a non-formal way. But you know, we find that that falls apart. So bridge programs are designed to really support that student in a structured way where there is some academic coordination, clinical coordination, case management, and we tend to find that students are incredibly successful when we support them re-entering school. Imagine that. Lots of professional development related to clinical practice, so cognitive behavioral therapy, treatment planning, measurement-based care practices, PBIS, all kinds of things. Okay, moving on. When we talk about the work that needs to be done, and April, I'd be interested in your thoughts on this too, but you know, unless you have the support for the initiative, unless you really establish yourself or establish the work as being necessary and important and worthy of allocating resources to, then it's going to fall on its face. We're not going to see success with it. So that was an early aspect of our implementation that was really important. And I guess my question to you is like, what are your thoughts around establishing buy-in from stakeholders relative to mental health in schools?
You know, I think we have to speak their language. And this is what I tell my students all the time. So if we're talking to administrators, then we need to speak their language. We need to talk about attendance. We need to talk about discipline. We need to talk about achievement and how whatever we're going to be doing is going to increase or decrease those in the way that administrators want. If we're talking about teachers, then we're going to talk about how we're going to help them with those achievement scores, right? Because bottom line is these kids are still going to be, for the most part, taking MCAS. We're not going to have pandemics every year where it gets, you know, taken off, hopefully. You know what? I'm just feeling like I'm talking bad news now. But we have to speak their language. And then for families, we're going to talk about how we're going to help their student be more successful and have the skills that they need to achieve whatever their end goal is in achieving. And so I think sometimes we just have to speak their language.
I love that. I think that's such a perfect segue into kind of discussing the work, right? But you gotta tune people into the outcomes of the work first. And you have to have that elevator pitch for every stakeholder group that you come across. I love that. So very cool. Let's keep moving. In terms of the structure of our initiative and kind of how we built teams, we had a district level team that was the COIN team, and that really worked to ensure alignment between buildings. The Mental Health Initiative Committee was responsible for meeting monthly, monitoring district-wide implementation of practices as they were brought to scale, assisting in identifying test sites to pilot new practices. We would meet monthly and basically cook up PDSA cycles and say, where should we drop this? Let's look at our data. Let's see where we need to improve. You know, this school is going to take care of this test of change. This school is going to take care of this test of change. So it was a collaborative effort to be able to, but also an effort that felt as though we were giving people the creative license to do the work. You know, we wanted to foster in our team an appreciation for innovation and not stifle innovation, which I think sometimes can happen. But when we could look to our our connection with the National Center for School Mental Health, and when we could look back on our PDSA cycles and show the successes that we had, it really fostered in our team an appreciation for, we should do this work, we should continue to move forward, and it definitely boosted buy-in for sure. I talked about needs assessments. I talked about working, to understand what we actually have to do. We've conducted a lot of needs assessments in Methuen. I'll mention one which I think was unique, and that was our evidence-based practice needs assessment. So we sent this survey out to all of our mental health staff across the district, and we asked questions around like, what do you do? What do you use for evidence-based strategies and programs and therapeutic models? what are the things that you bring to the table, and then also ask questions around, you know, what populations of students are you comfortable working with, what presenting issues are you comfortable addressing. So, you know, this was a dually purposed tool. You know, the forward-facing purpose was to be able to understand the needs of our staff relative to mental health professional development. You know, wanting to understand how we could develop a professional development plan for the upcoming years that would address the needs of our staff so that they could feel good about the work that needed to be done across a comprehensive school mental health system. So things like cognitive behavioral therapy and dialectical behavior therapy and treatment planning and psychosocial progress monitoring. The insidious and backwards, or I guess behind the scenes use of this tool was to generate buy-in, because ultimately we had a lot of people checking off a lot of things, and it made the idea of evidence-based practice less scary. Because people were checking off, yeah, I do that. I also do that. I'm familiar with that tool. I'm familiar with that program and that practice. So, you know, when it comes to talking about evidence-based therapeutic practices, I think sometimes people get a little bit scared of what that means. But this was a way for us to ultimately say, no, you're actually doing a lot of this work, and we want to support you in doing it by offering you more support. I do think that mental health staff readiness is probably one of the most important concepts or tasks that is necessary to implementing a comprehensive school mental health system. I think that we need to ensure that our staff are ready and that they have the skills and training and knowledge required to be able to do the work in a way that they feel good about it. That means that we're going to be pushing some people into a new direction that they're maybe not comfortable with 100%. And it means also setting a standard for what we care about. And when it comes to this topic, it's pretty easy to be able to say, you know what, we're going to do the thing that is best for kids, and that's going to be the standard. We know that our kids need more mental health services and supports. We're going to position ourselves such that we can do that. And by using that logic, it becomes very easy to select the training that is necessary to be able to get out to everyone and set a foundation for what everyone should be doing. From a training standpoint, April, what are your thoughts here?
Gosh, so my hope is that some of you guys who are school counselors, school social workers, SACs in here, have the ability to either reach out to your programs or have the confidence in order to provide some of this training yourself. You guys are just a huge wealth of knowledge that you could bring to your school and help your administrators to come up with some idea of developing some kind of professional development.
No, that's fair. I think the other piece too, right? We talked about this idea of a comprehensive staffing model, and really that's that defined, you know, setting out at the beginning of the work and really saying that we're not going to say, you know, I worry about when we say to a student, like, you're going to get your mental health care over here, and you're going to get your academic planning over here, and then if you have any kind of social services needs, that's up the hall. And then post-secondary planning is going to be a separate person. You know, I think that leads to some inefficiencies. I think that leads to some fractured service delivery. And I also want to just point out the very real fact that these problem areas bleed into each other. You know, having a conversation about post-secondary planning that is not informed by a student's mental well-being, or that is not informed by their social determinants of health, that's a problem. And I think comprehensive care requires that we have a comprehensive view for the services that we provide to students. In terms of professional development, this is a sampling of some of the things that we did to ensure that our staff were going to be ready, that they were going to be able to provide evidence-based services and supports across all of those tiers. Some of this is definitely for all, right? We have to make sure that the professional development we provide is not just for those specialized instructional support personnel, but also for all of our teachers. You know, tier 1 is for all by all. And that means that from a trauma-sensitive classroom standpoint, or from an SEL standpoint, or a PBIS standpoint, that everyone's on the same page and speaks the same language. We're going to keep moving. This is important. We'll talk about this. Community partners. You know, I talked about previously that it was incredibly important that we leveraged our community-based partners. We did this by establishing and drafting MOUs with those community-based partners. You know, what did we ask for? We wanted more services for our kids. We wanted those services to be quality, and we wanted the data that was associated with those services so that we could show the value of those services and the value of that partnership. And what did we offer? Time, space, and referrals. Time during the day, space in our buildings, and referrals to these community-based mental health staff members. The reality is that resulted in a 15% increase in mental health staff available to all our students overnight for no money. And that's the key piece there. There's a huge sustainability to these partnerships. The reality is that it is a wasteland after 2 p.m. for community-based mental health providers. But during the day, they've got lots of time. If you invite them into your buildings, they are happy to provide services. We saw a massive increase in the services that we were able to provide to students over the course of 3 years, newer data pending. And the types of services were also much more diverse. Diagnostic evaluations, individual and family therapy, consults. Wraparound was established as a function of having these individuals in our buildings working with our staff in a coordinated way. Jump over that. I think part of this is also just being sensitive to community partners in general. You know, we've certainly partnered with a fair number of community-based mental health agencies, but also, you know, why not reach out to the universities around you, the colleges around you, to be able to leverage professional development, to be able to be thought partners in your implementation, to be able to provide resources, and also to foster research partnerships that I think are incredibly important to closing that research to practice gap that we know exists. There are plenty of researchers that are very, very happy to provide training and time and expertise in exchange for the ability to look at a little bit of data. And that can lead to some wonderful outcomes for sustaining a comprehensive school mental health system. I don't want to be insensitive to parents and students as well. And early on, we established the Mental Health Parent and Student Advisory Council. If we are not ultimately providing care in a way that is sensitive to our kids and our parents and what they want and need and the things that they have to say, well, then we failed. You know, that is why we do what we do, is to make sure that our kids and parents have a voice relative to the services and supports that we provide, that they feel heard, that they feel supported. So this is an ongoing effort. We're in our second iteration of this council. Got cut off by the pandemic a little bit, but we're looking to expand into the grammar schools pretty heavily so that we have a K-12 parent-student advisory council. Yeah. We'll talk about this very briefly. Just, you know, again, marketing and promoting mental health programming I don't think comes naturally to people who are sitting in positions as school counselors or school adjustment counselors, or directors or supervisory positions even. But the reality is we have to put on the table, this is why we're effective, this is what we do, in order to be able to leverage the support that is so necessary, and ultimately to expand the services and support available to our kids. So I would, you know, I didn't get into this gig to, you know, market and promote and develop advertising materials, but I find myself doing that. It's important, you know, I look for opportunities now to put our work on the table, a la the MTA presentation that you're currently seeing. So I want to get into some specific aspects of a comprehensive school mental health system. So far, April and I have talked about kind of the broad strokes, right? The staff readiness piece, the staff, the different roles, the conversation around readiness, conversation around what the system constitutes, how to generate buy-in, teaming, some discussion around partnering, some discussion around needs assessment, resource mapping, data. Now, some specific components of a comprehensive school mental health system. The first, near and dear to me, is mental health screening. And we started this not knowing what we were doing, no idea, had never screened before. But there are some specific things that we have to do when we're going to conduct universal mental health screening. You have to select some measures. You have to actually decide what you're going to screen for. I'm going to gloss over much of the details of this because I want to make sure that we get through everything. And you know, we could talk about screening for like 6 hours, and I would be fine with it, but I think you'd probably be sad. I don't want to make you sad today. So one of the first steps in screening is identifying what population or the needs of the population that you're going to screen. You know, what tool are you going to use to actually get to that presenting issue? Funding barriers, that's a piece that we have to account for. And we also want the data to be actionable. Consent is something that I would strongly recommend that you pour over with some time. You know, what options do we have? How can we ensure that we're doing this in a way that gets to the larger population? We ultimately started with active consent, which if we need a little bit of a definition here, right? Active consent, can I do the thing? Passive consent, I'm doing this, tell me not to. We have adopted passive consent with opt-out procedures for universal mental health screening, which puts it in the same category as all the other things that we ask passive consent for. So things like screening for vision and hearing and for dental. You know, we wanted to put mental health on the same level as some of these other things that we use passive consent for. Ultimately, this is the message that goes out a couple times a year to be able to secure passive consent, opt out. If you don't want to be a part of this, no problem. But the reality is that less than 1% of parents and families opt out in a given year. It's just not something that's happening. If we were to try and secure active consent, on the other hand, we would see a significant drop in the number of students who would participate in screening. This speaks for itself. Please find ways to screen using web-based tools. We use Google. The reality is that I can send out the screening measure using a Google form, and 20 minutes later, we have counselors who are responding to the data and conducting coordinated follow-up. These aren't hard to score, but it's hard to score anything when you have to score 2,000 of them. So just, to be able to total and sort within a Google sheet is a dream. For those of you who are saying, oh my God, I can't believe you're using Google, isn't that unsafe? I would ask, where do you keep all your IEPs and 504s? But I think it's worth noting that if you're a Google school or a Google district, the data sits on your server and you are fine. If you are using your own personal Google account, I wouldn't do that. That's not secure, but use the tools that your district has purchased and that has secured to secure all of the data and important files that you have. So there's this evolution of practice that happened with universal mental health screening, right? Going from active consent, one student, one day, one small test of that measure, to passive consent and opt-out procedures with an entire district, paper and pencil screening to electronic screening, single student or small group to using the school-wide advisory program, to grade level or school-wide screening, and then administering, single student screening to use of the advisory program or tech courses, so that we could leverage the entire staff and have our mental health staff waiting in the wings to respond to the data. Massively important. Coordinated follow-up is in my mind, the most important part of screening. We should not screen if it is just for the sake of screening. These are actionable data. You have to respond to them, otherwise it's very unethical. We've gone through this. 100% of students are responded to within 7 days. That's the gold standard from the literature, but anyone who needs follow-up care relative to suicidal ideation or self-harm gets that immediately, same day. Incredibly important. We did put crisis teams on call to respond to the data. We didn't know at the beginning what we were getting ourselves into, so we wanted to be super prepared for contingencies. We didn't ultimately need these crisis teams, but I would strongly recommend that you call up your local community-based mental health provider and say, hey, you might be getting some referrals today, maybe an influx, putting your in-house crisis teams on call. It's just a way to create a buffer between your implementation of screening and potential crisis. This is an important feature for all, right? Just to understand screening and what it's for, right? We screen to identify students primarily. There are a lot of other uses of the data, but we saw a 66% increase in the identification of students who required mental health services for internalizing concerns. So things like anxiety and depression after our implementation of screening. So that tells me a couple things, right? We had other ways to identify students, parent referral, student self-referral, teacher referral. They were working, but we were missing a massive swath of the population prior to our implementation of screening. We are really good at identifying students with externalizing behaviors, right? It's easy to see a kid flip a desk. It is really, really hard to see students suffering with anxiety and depression. So I think that is one of the reasons why I would strongly recommend screening as one of the foundational practices within a comprehensive school mental health system, because ultimately without these data, we're missing a ton of students. Just a quick graphic of what we screen for. You can look at this after. This is relatively important, right? When we talk about screening, we're talking, these are students in grades 5 through 8 and results for an internalizing measure, so depression and anxiety. So this is the kind of data that I can bring to a stakeholder and say, this is a problem for your school and district. 13.36% of students in grades 5 to 8 scoring in the moderate to severe range for depression or anxiety. That is a massive problem. That's not a problem that is unique to Methuen. That's a problem that is across the country. And to be able to paint a picture of need like this moves stakeholders to a point where they want to do something about it. Comparing these data to the high school data, where we see 20 to 22% of students scoring in the moderate to severe range on depression and anxiety scales, also shows that if you don't engage in preventive, proactive services, it's only going to get worse. Happily, because of the services we provide, it's getting better. We're seeing students scoring in a moderate to severe range less, about an 8.5% decrease in those ranges on a anxiety scale, and then 11.5% increase in the no concern range. So moving in the right direction in both directions, at both extremes of the data, and similar on the depression scale. Bottom line, less moderate to severe, more no concern. That's what I would want to see over 5 years. I'm happy to show you these graphs instead of graphs that show completely. Aggregated psychosocial data. We'll get into this a little bit, right? I don't want to wax poetic over the data too much. I'm a data nerd, but I'm gonna pull myself back a little bit. But you use these data to identify students, but you can also use these data to inform the design and delivery of SEL curriculum, to inform prevention work, to conduct an ongoing needs assessment, to identify funding and resource gaps, to understand what you have to purchase in terms of human and material resources to address depression or anxiety or trauma. We're going to talk about evidence-based services and supports, and I've talked for quite a bit. I'm going to shut up for a minute, but I'd love to hear your thoughts around evidence-based services and supports, April, and kind of what training programs are doing now to position school counselors to provide these kinds of things.
So I think, well, I hope we're teaching students how to define evidence-based practices, and also to find them and to critically evaluate whether or not they're a good fit for different schools. So a number of my students, and I'm gonna throw a shout out. So in the spring, I teach a evidence-based school counseling practices course, and the students have to do a needs assessment. They have to do a program evaluation of a school counseling program. And so I'm always looking for partners in the area that my students can give out give you guys these forms to fill out, and then they evaluate all the data and come back with an actual report of what they believe are some strategies or things that they've learned from this data. So please, you'll have my email at the end. Email me if you guys are interested in partnering in the spring for that. So they're learning how to do needs assessments. They're learning how to run program evaluations, but they're also looking at what kind of evidence-based programs are out there. Are they tier 1? Are they tier 2? Are they tier 3? And how can we determine whether this is a good fit for the population that we're working with?
That's awesome. Thank you for that plug. I love that. Okay. So we're going to talk a little bit about kind of like what do we mean by evidence-based services and supports, how have we expanded and improved those services and supports within Methuen. We tried to balance between all the tiers, ensuring that we were implementing things that were research-based and that were going to line up with our students' needs. Ultimately, cognitive behavioral therapy is a gold standard in terms of therapeutic practice and is very well researched in terms of its effect on anxiety and depression and trauma. We provided professional development across our district to all mental health service providers that would bolster their use of cognitive behavioral therapy. Simple, like two sentence description of what cognitive behavioral therapy is for our teachers in the room, right? So the way we think impacts what we feel and how we behave. The way we behave impacts how we think and we feel, right? This cognitive triad, this piece right here, I think you can see me like moving my cursor around. But thoughts impact feelings, impact behaviors, impact outcomes. When we tend to think poorly or inaccurately or with a lack of rational thinking, we tend to feel poorly, negative. We tend to then behave in ways that are negative or that don't align with our with positive outcomes. And when we have negative outcomes, we tend to think poorly again. So it's this horrible interplay between thoughts, feelings, and behaviors that result in mental dysfunction and poor thought patterns. So a lot of cognitive behavioral therapy is about identifying those negative automatic thoughts and reframing them and replacing them with coping thoughts. You are now all cognitive behavioral therapists. Congratulations. We implemented this across individual sessions and also in group. Group is the forgotten tier 2 within schools. It happens in theory, but I don't see it happen a lot in practice where there are well-run groups. When we talk about group-based services, I also want to just give a nod to, of course, there is a place for social skills groups and for lunch bunches. There's always going to be a place for things like transition groups or specific presenting issue groups. But I also think there's absolutely a place for cognitive behavioral therapy delivered in groups to students that present with anxiety and depression. Closed groups, 8 to 10 weeks, 8 to 10 students, and true therapeutic care happening. We had all those things, but we needed more in order to efficiently and effectively address the prevalence rates that we were dealing with at the high school level. So we adopted a group therapy model, and I'm going to skip over some of this, but the idea is ultimately that this is an effective model that can be delivered in schools. We've expanded this across our high school, and in this past year, we used a grant to be able to develop a group therapy or to ultimately position some group therapy coaches to deliver training to our grammar schools and scale up the model of our group therapy program into the K-8 buildings. So this is something that is really hitting on that preventive, proactive service delivery. We're not talking about the students necessarily that need the most intensive individual care. We're talking about students that are presenting with concerns, presenting with risks, or that ultimately have data associated with them that we want to be able to address early. So we're talking about at risk and addressing it before it becomes crisis. just a little bit more psychoeducation, intro to CBT language. You can kind of take a peek at this afterwards. This is an example of a CBT thought record that we use. So trying to get students to reflect on the troubling thoughts that they're having, more as homework, right, between sessions, so that when they're in session, they can talk about how they address this in real time, and then we can process and problem solve. We've talked about this. We can jump to there. Ultimately, this is some selected data from one of our mixed internalizing groups. So students that presented with both anxiety and depression, we saw that close to 70% of the participants showed improvements on one of the measures that we were using for depression. There was on average a 38% reduction in symptom presentation over the 8 weeks of the actual group. There was a baseline data point that is in here. So that was not a session, that was before sessions began. And then we had a show rate of about 84% for group, which is unheard of with adolescents, especially in outpatient settings. You don't get students to show up to sessions as much as you would like, unfortunately. I'll talk very briefly about intervention treatment planning. Bottom line is we need to ensure that we have a plan for our students that is formal, and that includes data collection, that includes an evidence-based therapeutic approach, and that isn't just us kind of flying by the seat of our pants. You have to be sensitive to the changes in a student's presentation over time. I think that's where psychosocial progress monitoring is going to come in, measurement-based care practices. About 5% of the students in Methuen have an associated treatment plan. Those are students who are receiving services at Tier 3. And this is just a very general conception of what intervention treatment planning looks like, right? We identify a problem, we collect data relative to that problem, we implement an EVP that matches that problem, we progress monitor, we adjust, we rinse and repeat. And then imagine this, we actually terminate the service once we have hit our goal. But termination of services is something we fail to talk about in schools. And ultimately that undermines our students' ability to go it alone, and to, we should be celebrating the achievements of students as opposed to locking them into endless service delivery. I worry about that, because the first conversation you have with a student about a service that you're going to provide should include a discussion about, the goal here is for you to not need me anymore. The goal here is for you to be able to do this on your own. We can skip over that. We talked about Bright. I love Bright, but we're not going to, I don't know that we have enough time to really go into it too much. I'll ask this question. I think this is worthwhile, and this is going to be for kind of everyone, but how do we know when our therapeutic interventions are working? I'd love to see in the chat for some of our service providers and for our teachers, maybe less about our therapeutic interventions, but how do we know that we are, how do you know that your students are learning the thing you want to teach them, right? What do you do? Waiting, wait time. People are typing away, I'm sure. Benchmarks, thank you, Deborah. So you actually measure something? Absurd. What else? Feedback from teachers, parents, and students. Okay, feedback. Check for understanding, exit tickets. Thank you, Anna. What else? I'm gonna guess that feedback, right, is a lot of times qualitative. I'm gonna guess that it's sometimes a reflection on, yeah, I think Johnny's doing better, or I think, yeah, Stephanie, you hit it on the head. Informal assessment, right? Moments of being available for learning. Classroom feels less fractious. Okay, and this is kind of what I'm getting at, right? We need to do better as school counselors and school adjustment counselors and school social workers and school psychologists at measuring the impact of our outcomes using quantitative measures. I think the teachers in the room, you reflect on data, academic data, an awful lot in your instruction. And one of the things that I want to really promote is the use of quantitative measurement in assessing how effective our treatment is. Otherwise, we're making statements like, yeah, I think he's doing better, or I'm pretty sure that, we're seeing growth. And that's, I cringe when I see that at an IEP meeting. We have to put our money where our mouth is, and say, our treatment impacts the outcomes of students in this way. Lynn is asking like behavior charts. That could be one piece, Lynn. That's something that's actually measurable if it's implemented with fidelity. But I'm talking more about things like psychosocial progress monitoring, which is the use of a measure over time to be able to get at the growth relative to psychosocial progress. So quantifying a student's rate of improvement, quantifying the response to instruction or intervention. Ultimately, what we know is that when we use progress monitoring tools in practice, that there is better student engagement in services, that the quality of the services improves because we're able to adjust our practice relative to the data, that we see greater consistency of therapy sessions, and our self-assessment and our professional growth improves. What are the things we're measuring? We're measuring things like symptom presentation, emotional regulation, specific behaviors. So Lynn, to your point, could you measure specific behaviors? You absolutely could. You could also measure symptom presentation. So I think, there are plenty of tools in the SHAPE system to do this. I guess what I want to promote is something like this, right? An idea where we can actually measure over time a student's self-reported anxiety or depression. These are not me drawing in with a crayon these the trend lines. This is computer generated. This is a student I worked with for about 16 months, 14 months, something like that. And ultimately, each of these points is a point at which I administered either the PHQ-9 for depression or the GAD-7 for anxiety. You can see some outliers. Those are going to happen, right? But it's about the trends over time. It's about the general trajectory of this student's symptom presentation over time. And what I can tell from these data is that the treatment that I was providing, which was weekly cognitive behavioral therapy, was addressing the needs of this student such that symptoms were decreasing on average over time. That to me is worth way more than any kind of qualitative assessment of the student's growth. You can get real fancy with this. 3-point moving average, this trend line represents, this red trend line is depressive symptoms over a period of about 8 months. You can see that it's actually moving in concert with the anxiety symptoms, which to me, from a clinical standpoint, told me that the relationship between the anxiety and depression for the student was pretty strong. That helps me improve my practice. That helps me to know that what I'm doing either is working or not working. Ultimately, it's not me just shooting in the dark. I actually can make a plan based on these data to inform my practice. No one point means much except for when you're planning the session that you actually administer this tool. So like use this as the mood measure at the beginning of your session, and then draw from that data that will really guide the session structure and the session agenda. I think that can really help to improve the engagement of a student in therapy, because you're actually addressing something that they just told you was a problem for them.
And I'm going to jump in here and also say, again, some of the things that I would probably recommend that you're keeping track of are attendance data too, right? Because if you're feeling less anxious, if you're feeling less depressed, then you're going to be at school and you're going to be engaged. So you're going to hopefully see an increase in attendance and possibly an increase in academic achievement. So kind of keeping track of some of those markers that really kind of speak our stakeholder language as well are important.
I think that's so important. When you can show that symptoms decrease over time as you fade services. Oh, and by the way, this pro-social measure of engagement, or this attendance data that shows that I'm showing up to school more, or my academic data that shows that I'm improving, you know, when you can show this going down and this going up, that just, yeah, I think it serves to reinforce how effective that treatment is. I think we're at a point where maybe we want to start to wrap up,
Yeah.
and go into questions. Do you want to take away the MASCA piece, and then
I just threw that in there. Just Massachusetts School Counselors Association. Our mission is to advocate for school counselors in the Commonwealth of Massachusetts by providing leadership, collaboration, and professional development. There's our website. We've had a ton of PD that we've been doing free via Zoom. We typically have our big conference in April. The first couple days. And so that might be something that you, even as teachers, would want to come, because there's so much that's covered there. And you guys are welcome to join the organization, or just join us for some PD. That would be great.
Awesome. I'm going to give a quick plug for the Massachusetts School Mental Health Consortium. Here's a fun map of the districts that have joined us. Really, our purpose and intent is to improve services for kids across the state, increase the quality and sustainability of school mental health services and supports. We are a group of about, like I said, 130, 140 districts, and we've been able to achieve a lot over the past 2 years, engaged a ton of people in professional development and resource sharing and collaboration. We meet monthly to be able to do this, and have also recently engaged in some remote learning sessions. We develop resources, we distribute those resources, a lot of coaching and implementation support. We've also funded a few districts in conducting projects that relate to school mental health, and we also do some advocacy work around school mental health funding, and also to try and improve efforts related to policies and practices for licensure in Massachusetts. Huge thank you to our sponsors. There they are. I would encourage you to take a peek at what we can offer. Ultimately, we don't charge anything. We just want you to be able to get some support around school mental health. So if you have any interest, you can certainly check out the website, you know, follow us on Twitter. First person to follow us on Twitter gets a $1,000 gift card to Target. I'm not going to deliver on that. I can't. But questions are welcome. I really appreciate all of you and the engagement during this session. And